Very good afternoon to everyone out there. We are now to the number 9 series of regular updates in COVID-19. Yes, I'm certainly not physically. I'm Dr. Go from National Institute of Health, the Director Institute for Clinical Research, and we have a break for Dr. Chris for the coming Hari Raya. So today, we are now looking more towards collateral damage from COVID-19. It is because we recognize as COVID-19 pandemic progresses, people who are not affected by COVID-19, which are majority of them, are having challenges in accessing to medical care, either because we are being locked down or because of the fear to go to the hospital. So today we have 4 people who care for people with chronic diseases such as chronic liver diseases, people who are facing end-of-life issues because of the disease such as cancer, and providing care in the home or home hospice care, as well as family medical specialists, family medicine specialists who care for children who need immunization, healthy children, and as well as healthy pregnant women who need to come for the antenatal check. So without further ado, I would like to welcome Dr. Rozita and as well as Dr.Tan, Dr. Vanitha, and Nurse Sunita. These are 4 strong ladies, and I'm a lady. So today is a lady team. For those who are healthcare professionals who need CPD points, do not forget to click on the online attendance sheet, and so that you will get the online certificate for your CPD points. Do make sure you have a correct email. And for question and answer, we will, after the 4 presentation, we have a Q&A. You can type your question on Slido, which will be shown on the slide, which is now shown on. So do get ready for your questions. The slides will be shown later after the webinar, and we do have a team of staff from ICR to prepare clinical summaries, and all these video slides as well as the clinical summaries will be up on all those channels that you can have access to. So now let's start with Dr. Rozita Binti Zakaria, the head of family medicine specialist who works in Klinik Kesihatan Health Clinic in Persint 18, Putrajaya. Rozita, thank you very much for coming on board.
Thank you for having me. First of all, Assalamualaikum and a very good afternoon to everyone. I will be talking on maternal and child health services during this COVID-19 pandemic at health clinics, how we embrace the new normal. So I shall share my slides. Okay, can you see it?
Yes, yes, we can see.
Okay, so this is my topic. So when we talk about vulnerability, we usually refer to a person in need of special care, a special support or protection because of the age or the disability and so forth, and the risk as well. And generally, pregnant mothers and children fall into this category as they are at higher risk of getting into a situation. And especially so, yeah, Dato, as we have lack of scientific knowledge on this group of people, as they are relatively less being included in researches. So generally, I think we can include them in people who fall into the vulnerable group.
Yeah. Can you share your slide on the bigger screen?
Okay. All right, this is the disclaimer. A little bit on the background of the maternal and child health services in Malaysia. It is the maternal and child health is an essential component of the National Rural Health Development Program in the 1950s, but it has evolved to become a very comprehensive service which is delivered in the health clinic on top of many other services that we deliver in our clinics. And typically our health clinics, actually we have categorized it into types 1 to 7. There's a typo there, 1 to 7 actually. And typically the working hours is like we start 8 to 5. We start off 7:30 for registrations, but there are some clinics who have extended hours and work until 10 p.m. and half days on weekends. So what happens during this COVID-19 outbreak? I think I must show this picture here with our photo of our DG, because everybody will listen now when DG talks. So the whole country can listen when DG talks. So he mentions here, I quote, walaupun dalam keadaan situasi wabak COVID-19 ini, KKM ingin menekankan bahawa perkhidmatan kesihatan ibu hamil dan anak adalah berjalan seperti biasa. So our service must go on, and we will have to perform all the services, including home visit for the mother and child. All right. So service must go on. Why? Because they are vulnerable, and we have to continue to provide them with safe and effective care to all our mothers and children. However, how do we run this service? It should now be in a different manner. The basis of this is for the protection of our healthcare workers and also to break the chain of COVID-19 infection. So maintaining a healthy workforce will actually ensure continuous quality care. And at the same time, we cannot compromise the quality of care to our patients. Okay, the same principles that we advise to the public should also be adhered to in our facilities. Here, the advice that we have been harping to them, to the public, is avoid the 3 Cs and practice the 3 Ws. So what are the 3 Cs and what are the 3 Ws? Avoid crowded places, confined spaces, and close conversation. And we have to practice washing our hands, wearing masks, and also warning about like cough etiquettes, not to shake hands now, just to put our right hand on our left chest to greet people. Okay, so we at the facility will also, at the clinics, will also have to adhere to these principles. Number one, we have to minimize crowding in clinics, minimize patients' contact time in the clinic and confined spaces, minimize close conversation, face-to-face conversation, handling by healthcare worker, and wash. We had to adhere to infection control, to PPE usage, and we have to still warn our staff about social distancing. Social distancing is not only for people outside, but also within the clinic as well. And also lastly, we also have to use digital technology. To minimize crowding and reduce the possibility of cross-infection, an analysis of the number of staffs and patients being in an area, in the same area, has to be done. So based on the analysis, a rearrangement of staff has to be done, and necessary changes to the work process should be looked into. At the moment, although we have a staggered appointment system in place, many patients do not adhere to it for many reasons. So this is the time and opportunity for us to emphasize, to re-emphasize on the importance of adhering to the given time and date of appointment. Early of this year, online appointment system has been launched, not for all clinics. It was piloted in Putrajaya, where my clinic is also involved, where patients can actually choose when they prefer to come to the clinic, the date and also the time. By having this, I think there will be a control on the number of patients coming to our clinic, as well as control on the number of patients waiting in our clinic area. So, social distancing can be practiced effectively within our clinic. And primary triaging at the point of entry is being carried out, and navigation of patients will be done effectively. And at the moment, plan and discussion has been in place to lengthen the operational hours of our clinics and to go on shift duties. So that's why I mentioned just now in the first few slides that typically we work from 8 to 5, and some clinics have extended hours and work until 10 p.m. and also half a day during the weekend. So now there are plans and discussion for lengthening of operational hours and shift duties. So all in all, there will be a limit to the number of patients. It will be easier for a one-to-one consultation with no sharing of rooms, hence a better infection control process. The plan is for clinics to operate from 8 to 10 p.m. with 2 shifts, but it will be closed on weekends. This is a example of primary triaging, where patients come in and will be triaged by our nurses and also doctors, and they will be navigated to where they are supposed to go to. And this is an example of the waiting area. We practice social distancing and to reduce the possibility of cross infection. Okay, the next is reduce patients' contact time in the clinic and confined spaces. To reduce this contact time, some strategies have been carried out. For example, for booking purposes, we actually do a pre-booking call, which is done via a phone call. Usually, pregnant mothers will come to the clinic and we entertain them and we book them immediately, and we do a detailed history taking, and also do assessment, risk assessment. So now we will do this pre-booking through a phone call. So the purpose of this is to do this phone call, and it will reduce the contact time of the patient in our clinic. Because usually a booking process will take about an hour or so, or even more, where a newly registered patient will come to the clinic for detailed history taking, risk assessment, physical examination, and lab tests. So by doing history taking and opening up the antenatal book, it will reduce contact time. And as I have mentioned before, one-to-one consultation with no sharing of examination rooms will also reduce this contact time and confined space in the clinic. Other strategies that we are emphasizing now is that to strengthen our value-added services by the pharmacies, where patients can get their medication through other means like locker for you. They can drive through and can get medication by post. Okay. And this is an example of our examination room, and minimizing close contact by face-to-face conversation. Usually for like what I've mentioned, booking and history taking through the phone can reduce the time and contact of the patient face to face. So, and we also now we are empowering the parent or the carer for our child health patients who comes for immunization, we are empowering them to self-perform procedures like measuring the height and length of or weight for the children. But of course, our nurse should also be there to supervise, and the nurses should plot it in the chart, not the parents. So all this have to be done without compromising the quality of care. And we also have online monitoring of antenatal and postnatal patients. We have checklists for patients that we need to actually check on, to monitor them. There is a checklist which has been developed, and the nurses can go through this checklist to ask certain questions through the phone. And also virtual clinic. This is another exciting thing that has actually happened. Our clinic in Putrajaya Persint 18, we have started off virtual clinic as a proof of concept. It's a pilot project. We started off in August 2019. And we started off with only just a few patients or NCD patients, where patients do not need to come to the clinic physically, but can be seen virtually. For example, if they are being started on ACE inhibitors and we have taken their renal profile and we ask them to come back in 2 weeks' time to review the blood results. So it can actually congest the clinic by having more patients. So this is what we have done virtually. So and when COVID-19 happens, we took the opportunity to expand our virtual clinic to include other cases as well. And the 3 Ws, what are they? The adherence to infection control, where our staff should be screened for symptoms and temperature before coming into the clinic every morning, and to emphasize on regular hand washing, use of hand sanitizers, and cutting their fingernails, and all that. All that has to be carried out. And PPE usage, staff should use appropriate PPE according to their work process. For example, for home visit, our nurses will still have to perform home visiting for patients that requires. So before going for the home visit, they will call the patients first to ask whether they are around in the house, and to ask whether they are having any problems, any fever, or have any contact with a COVID patient. They have a checklist on what to ask and what to do. So, and when they go to the homes, they will wear the appropriate PPE for examination of the child and the mother. And we have to warn our staffs. Usually our nurses will, and nurses especially, they will shake hands with our patients. They are trained to salam, salam, senyum. They have all that salam, senyum, and all that. So now we tell them no more handshakes, but you should still greet the patients and talk to them nicely. Social distancing should be practiced, and cough and sneezing ethics, and regular disinfections of our workstations. Okay, this is what they do regularly. And lastly, by using digital technology, like I've mentioned just now, virtual consultations in clinics with existing facilities, and for suitable patients. Not all patients are suitable for virtual consultation, and also the online appointment. So when I look through what other countries are doing, they have actually, for their antenatal mothers, it is recommended by WHO that they have this antenatal contacts 8 times throughout the pregnancy, at 12 weeks, 20 weeks, 25, and so forth. However, what they have done is an alternate modality of the antenatal contact, where they have 4 face-to-face and 4 remote contact. With this remote contact, they should also have they also have a risk assessment tool where they have to ask the patients. So this can also be incorporated into our service, but of course we will not stop at what we have done. We will also still improve in whatever we have done now. Maybe we can also adapt to whatever other countries are doing. So in conclusion, the process of adaptation of the new norm will of course take some time. It creates confusion among staffs, among patients, and sometimes there are dissatisfaction. But finally, we will have to accept the new norm. Okay, all right, thank you for your kind attention.
Thank you, Rozita. Wonderful. Give an overview of how the clinic has been doing and will be doing at the new normals. Yeah. Next, we would like to invite Dr. Tan, a senior consultant hepatologist who care for many patients with hepatitis B and C, as well as those with liver failure. She's also a very keen researcher, and her interest of research again is on liver failure and hepatitis. We would like her to share with us some of the analysis she has done on data we collected COVID-19 patient who has also chronic liver diseases. Thank you, Dan. Go ahead.
Thank you, Dr. Go. Thank you for the kind introductions and the invitation. Oh, why am I in the summary slide? Sorry, it's just my slide. Okay, my topic for today is on liver injury in COVID-19. This is the disclaimer slide from the organizer. So I'd like to address what are the types of liver injuries in COVID-19, how common are they, and do they matter? And also would like to discuss some of the possible mechanisms of liver injury, and whether people with pre-existing liver disease and develop COVID-19, is it important, does it matter? And I'll move on to recommendations on management of liver injury in COVID-19 patients. And also, finally, I will end with caring for liver patients without COVID-19 during this pandemic, during in the new normal. Abnormal liver function tests have been reported from the beginning. It's usually transient in mild COVID-19 and does not require specific treatment beyond supportive care. Patients with abnormal liver function can be as high as 53% or as low as 16%. But patients with severe COVID had increased incidence of abnormal liver function. ACE2 is the functional receptors for the SARS-CoV virus, and it's present in many organs. It's present in the central nervous system, the airways, the upper airways, the vasculatures, the lungs, the liver, the gut, kidneys, heart, and our eyes. In the liver, it's present more in the cholangiocytes than the hepatocytes. In autopsy tissue samples, when we look at the viral load of this SARS-CoV, to quantify it, of course, it's very high in the lungs and the pharynx. It's also found in the liver, as well as the kidneys and the heart, and small number in the brain and the blood. Meta-analysis based on 12 studies show the pooled prevalence of liver injury in COVID-19 patients is about 19%. The prevalence of increased AST is 21%. The prevalence of increased ALT is somewhat lower than AST at 18%. Prevalence of increased total bilirubin was 6%, and the prevalence of decreased albumin was 6%. And meta-analysis also show deranged liver biochemistry is associated with more severe COVID-19. So what is the significance of elevated liver biochemistry? Based on a study from China for more than 400 patients, abnormal liver function test at admission itself is associated with higher risk of severe COVID-19. And another study from New York in more than 1,000 patients, multivariable analysis show liver injury at presentation with an odd ratio of 2.53 and is independently associated with higher risk of poor composite outcome of ICU admission or death. Other factors are, of course, what we know, older age, comorbidities, and respiratory problems such as tachypnea and severe hypoxia. Severe liver failures and injuries with SARS-CoV-2 infection had also been reported. One case was in a 65-year-old male, throat swab positive. On admission, the ALT was only mildly elevated as mild hepatitis. He developed mild to moderate ARDS, required oxygen therapy, and he also requires some vasopressor. He was given antiviral, Calitra and interferon beta. The echo was normal, the ultrasound was also normal. Hepatitis increased to about 400, and subsequent to that, the INR also increased, the bilirubin also increased. Eventually, he had poor liver prognostic score, MELD score, about 40, and he passed away. There was another case of a 59-year-old well-controlled patient with retroviral disease. This patient had severe hepatitis. The AST was about more than 1,200. The ALT about 700, and she was negative for other hepatotrophic virus, hepatitis A, B, C, hepatitis E, CMV, EBV, and also autoimmune liver markers. Luckily, this patient survived, and the patient was discharged. I work in a non-COVID hospital, and I only have the opportunity to look at 7 cases with the help of my colleagues, Dr. Law In Su, Dr. William Yap, and Dr. Yasmin Ghani. Of these 7 cases are PCR positive COVID-19. 3 of them had acute liver injury. Acute liver injury is defined as patient with jaundice, which is total bilirubin above 51 millimole per liter. Liver enzymes, ALT, AST, alkaline phosphatase, or gamma GT above 2 times upper limit of normal, or INR equal above 1.5. So these 3 cases have acute liver injury. The first case was a 36-year-old male diabetic who passed away. Second case is a 59-year-old male with diabetes and hypertension. At the time of data analysis, he was still tubed in ICU. The third case, a 58-year-old male with similar premorbid history, diabetes and hypertension, and still tubed at the time of data analysis. So I bring you through the liver function test. The ALT on admission on the 2 patients who are still alive are actually quite normal, but the patient who passed away actually was high on arrival. And the peak value of the patient who passed away was about 3 times upper limit of normal. And the others are about 3 times or 4 times upper limit of normal. And if you look at the AST on admission, the one who passed away also had a higher AST, and this AST can go up to about 8 times upper limit of normal, so between 4 to 8 times. So this is an AST predominant elevations in terms of the liver injury. In terms of alkaline phosphatase, they were quite normal on admission, and they increased to about 2 times upper limit of normal at the peaks. And the bilirubin, the patient who passed away peaked at 125, and the others also had enough rise in bilirubin to be considered as acute liver injury. And the INR can go to about 1.5. This slide shows a series of moderate to severe COVID-19 from Wuhan. And you can see they have multiple complications, and acute liver injury also occur in this patient, about 5% more in those who did not who pass away than those who are recovered. So what are the mechanisms of liver injuries? These are postulates. Based on autopsy tissues of the liver, can be shown maybe there is direct viral and cytopathic effects because we could see moderate microvascular steatosis and also activities in the lobular area and the portal area of the liver tissue. And also, you can see acute portal and sinusoidal thrombosis and also endothelial thickening in the liver tissue. So possibly there is some intrahepatic vascular related damage as well. Of course, drug-induced liver injury can happen. This is also can be supported by the microvascular steatosis on the autopsy liver tissue, but drug-induced liver injury is a diagnosis by exclusion. And in the patients with COVID-19, common drug-induced injury that you need to consider are those from the antiviral remdesivir and also tocilizumab. And other drugs are like hydroxychloroquine, Caletra, antibiotics, and antifungus also can cause drug-induced liver injury. The liver injuries can also be happening because of the cytokine storm, the imbalance in the immune system, and liver could be part of the multi-organ dysfunctions. So this is part of the viral sepsis hypothesis. Another cause of liver injury could be the pneumonia-associated hypoxia and also ischemic hepatitis. Sorry. Okay. What about those patients with pre-existing chronic liver disease and what happened to them when they develop COVID-19? Initial series here shows there is very small number of patients with chronic liver disease, but this series has a lot of missing data in terms of what are the underlying conditions. The subsequent study shows from UK, from using electronic health data records on over 17 million patients, they found that chronic liver disease is a risk factor for inpatient death from COVID-19. Another series from America showed that chronic liver disease is associated with significantly higher mortality. The mortality is even higher if the patient has liver cirrhosis. And the etiologies of this chronic liver disease and cirrhosis are fatty liver disease and also non-alcoholic steatohepatitis. This mortality risk is actually independent of the well-known factors of mortality, the high BMI, hypertension, and diabetes. So this brings me to this slide about fatty liver disease. Fatty liver disease used to be called NAFLD and has been now changed to MAFLD, which stands for metabolic associated fatty liver disease. So what happened to them if they develop COVID-19? Why do I want to discuss on this is because MFLD is very prevalent in Malaysia. In the general population, it's about 38%. But if you're a diabetic patient, type 2 diabetes is close to 50%. The young adults are also not spared of having metabolic associated fatty liver disease. In these studies, using a non-invasive test of fatty liver disease, either by ultrasound or using some simple parameters to calculate the hepatic steatosis index, they found that patients with MAFLD had higher risk of COVID disease progression, higher likelihood of abnormal liver function from admission to discharge, and a longer viral shedding time. I think we do need to look out for patients with cirrhosis who develop COVID-19. This is an international registry of a cohort of patients with liver disease, 491 from 28 countries. In this cohort, 209 of them have cirrhosis, and you can see patients with cirrhosis, the death rate is about 36%, compared to those without cirrhosis at 7%, and even those who had liver transplant were far better at 17%. And the etiologies of liver cirrhosis were alcohol in this cohort, and also this non-alcoholic steatohepatitis, the metabolic associated liver disease, and also viral hepatitis. So what are the recommendations on the management of liver injury in COVID-19? When we look at the liver function, if it's elevated in patients with COVID-19, you should check for viral hepatitis B and C. Review the medication in case it is a drug-induced liver injury. If you consider this patient could have biliary obstruction or venous thrombosis, then an ultrasound is indicated. Otherwise, probably it's best not to have exposed the patient to more injury. And if the liver function is stable and improving, you just continue to monitor. But should the liver function worsen, you should think about whether this is ischemia, myositis, cytokine release syndrome, or it could be drug-induced liver injury. There's no specific therapy. If the patients are found to have hepatitis B and you're considering whether the patient may have a hepatitis B flare, or you're considering whether to start immunosuppression as part of the treatment of COVID-19, the patient could be started on hepatitis B treatment. The presence of abnormal liver biochemistry should not contraindicate the use of investigation or off-label therapies unless it is very, very high. The regular monitoring of liver functions is actually recommended in all hospitalized COVID-19, especially those on remdesivir and or tocilizumab. So what about treating liver disease alongside COVID-19? I've shown to you patients with cirrhosis a higher mortality. So we need to keep this vulnerable group safe. We need to educate our patients and caregivers and also healthcare workers. Thank you, Dr. Rozita, for pointing out there's so many things that we can do. We can streamline appointments, we can use, and also the procedures. We can use tele-reviews or teleclinics. Actually, endoscopy is an aerosol generating procedure. So we use endoscopy a lot for our chronic liver disease patients, especially cirrhosis, to look for whether they have varices, and then we start beta blocker. But now we could possibly consider starting beta blocker in a selected group of patients who has studies shown at high risk of varices without even doing the endoscopy. And liver transplantation is actually life-saving emergency surgery for acute liver patients, patients with high MEL. We need this as an emergency surgery for this group of patients. So in summary, SARS-CoV-2 has a broad organotrophism, abnormal liver chemistry, prevalent and possible multiple factorial, and usually mild or transient in mild COVID-19, but severe injuries had also been reported. Abnormal liver biochemistry or liver injury at presentations predicts severe COVID and high risk for poor outcome. Patients with pre-existing chronic liver disease, especially those with cirrhosis, high mortality of COVID-19. So we have to take cognizance of this in their management and adaptation of our care plan for this type of patients. Thank you very much.
Thank you, Dr. Tan, for analysis of liver disease and COVID-19. I would like to encourage people out there, the clinicians who are caring for other patients with chronic diseases such as cancer, chronic kidney diseases, coronary artery disease, and pre-existing lung, chronic obstructive airway disease, asthma, as well as diabetes, hypertension, and stroke, to have a kind of systematic analysis like what you have done, so that we who are caring for non-COVID-19 should now start to have this care plan based on evidence, so that these people will be properly treated, especially if they also have COVID-19. So thanks for this wonderful comprehensive presentation. So next come the very important topic of end-of-life care. As you know, COVID-19 doesn't care whether you are rich or poor, young or old, but people who are vulnerable are those who are already sick with various diseases which have no curative management. So end-of-life patients are either being treated in special institutions like in hospice care facilities or at home. In Malaysia, most of the people with end-of-life conditions are being cared for by the family members and the community hospice services. We are very lucky to have a team of these wonderful angels who, even during pandemic and lockdown, continue to care for the hospice patients at home. We welcome Dr. Vanitha, Thangaratnam, and Nurse Sunita. They are from the Kasih Hospice Care Society with more than 10 years experience in providing end-of-life services to people at home. Kasih Hospice Care Society is a not-for-profit NGO and has been existing for a long time, for 20 over years. and they care for people around KL Selayang areas, which are actually hot red spots, red zone. And some of the patients are really worried initially that we may not continue our home care, but this wonderful team of 2 doctors and 6 nurses continue their care. So we would like to hear from Vanitha and Sunita on how they go about doing it. How do they feel going to a family home with unknown environment and risk factors? And how do patients feel when you visit them? Thank you, Vanitha and Sunita.
Good afternoon, everyone. Thank you very much, Dr. Go. I think so you've mentioned part of my first and second slide. Yes, we are an NGO and we are charitable. And sorry, just let me move my slide. Yeah, we mainly do home visits to patients with life-limiting illness, with stage 4 cancers and stage renal failure who have ceased dialysis. We cover an area of starting from Putrajaya all the way to Bukit Beruntung. So that's quite a wide coverage, going through many roadblocks during this MCO. And each of these areas actually covered by one designated nurse. So prior to our MCO, about 2 weeks prior to it, we actually started doing some changes to our normal routine. It was just minor changes. It was just minor changes, meaning is the team of 2 doctors and 6 nurses were divided into 2. And we actually started having our daily debriefing separately while we were trying to have physical distancing between ourselves. So it went on well till MCO was established on 18th of March. So based on discussion by the board of directors, we had to actually start working from home. So we still continue on with our daily debriefing via Hangouts, going through all the phone calls of patients that were made the prior day or any home visits which are done. And we also at the same time identified patients that may require home visits during this MCO. So this MCO, we actually limited our home visits to mainly patients who were dying. Meaning is they weren't able to swallow anymore and required the insertion of subcutaneous pod and subcutaneous medications to keep their pain and symptoms under control. We continued making weekly phone calls to each and every patient under our care. But for patients with uncontrolled pain and symptoms, we did daily phone calls and video calls, and we were still seeing is whether they need a visit. One of our doctors actually designed a video because of most of our patients having low immune system. They are high risk of getting a COVID infection. So we made a video informing the patients and family members that it is risky to go back to hospital. So to liaise with the hospice medical team, if there is a need to either top up medicines or if there are any uncontrolled symptoms, they will contact the medical team and we would see what can be done. If it can be controlled within means within a home visit or home, we would do. If not, we would actually liaise with the doctors in the hospital and try work something out for the patient. Yes, telemedicine is not an ideal way to provide hospice care. Hospice care is about visiting patients, being there for the patient. But yes, we have to move along and do changes. But whatever visits we did during the home visit, during this MCO, we did a health risk assessment as basically everyone was doing. We assessed the risk for COVID, and if we actually needed to go in, we wore full PPEs. So, sorry, my slide keeps running, sorry. Yeah. We had actually very good assistance from palliative care unit, Hospice Selayang. We are very thankful for that because there were cases where patients' medications had finished, family members were fearful of going back to hospital, and they will ask us, yes, because of those transporters were delayed and any other medicines weren't coming into us, They were very good at topping up medicines. We managed to actually liaise with them, and family members just had to go and pick up medicines. And also when it came to admission of patients in the hospital, we just discussed the case and they will let us know how to go about so that there is ease of admission for the patients within the hospital without bypassing the accident and emergency. Yes, everyone had a lot of challenges during this COVID. So some of the challenges which we face are basically fewer family members allowing us into the house. Even though patients got symptoms, they rather we do teleconferencing and try and manage pain, or they don't mind coming to our office and collecting, but they were scared that in case we actually bring in the transmission. Yes, everyone was doing teleconferencing, but at the beginning of MCO, because of cable problems, we had a lot of poor internet connections during teleconferencing. So it became quite difficult trying to view patients and assess their condition. Some, as we know that a lot of family members couldn't travel. So we had some homes where it was just two elderly people there. Yes, they had a smartphone, but they were unfamiliar on how to use it. So when we needed a video, it was quite difficult till we could get someone in to help get the video done of how the patient was. Also, we had decreased number of medical equipments to be loaned out because when late patients' family members return the equipment, we got a transit period of about 2 weeks before we clean. We check the equipments before it's loaned out to the next patient. And also, this is the wrong time to die because we've had a couple of cases where patients died at home. So the normal procedure is if there's a death at home, the family members goes to the police station and get the death certificate. But since the MCO, it's been quite difficult because the police are not so convinced, even though there is supporting documents stating a patient's condition, they are not convinced that the patient died of complications of the cancer or end-stage renal failure, but they suspect COVID and they member needs to bring the body back to the hospital. So it became quite complicated. Yes, family members found it difficult to visit their loved ones. Recently, I had a case where a patient was actually dying, and the only family member which was there was the wife. Yes, he had 2 kids, but they were overseas. And when I went and visited, and I managed to have a teleconferencing with both the kids. One was in Australia, one was in UK, explained to them that things are deteriorating and they understand and they knew the challenges which they were facing in coming or flying in because they were working and they knew this quarantine. So I sat with a wife who was the main caregiver and I explained to her, okay, in the home setting, these are signs normally we see when a patient is just got a few hours or few minutes to live. The wife was wonderful. She was very alert and she noticed the signs. So when she noticed that patient was actually already gasping, and she just immediately video conferenced the kids. And as the patient was taking the last breath, the wife was next to him and the kids were watching through video conferencing. And it was so good because the wife said is, you know, even though my family can't be there with me, you know, this teleconferencing helped me through all this process. So, yeah. The other challenges is, yes, we do help risk assessment, but some patients are not truthful. We had this case where we get most of the referrals from private hospitals and government hospitals. Yes, we got this referral from this government hospital stating on patients got stage 4 cancer. So when we did a call and patient was fine initially, but subsequently developed shortness of breath. So when we decided that we wanted to visit, the family said, no, he shifted house. So we couldn't visit him. Then subsequently, when we followed up with a phone call, found out that he ended up in hospital. After 2 days, the sibling calls us up and said, you know, he actually died of COVID. So it becomes quite difficult for us, is even though when we do health risk assessment, family will say everything is negative, but yeah, we do not know the true pictures. Burnout, yes. Being caregivers, everyone goes through burnout, continuously caring for a patient. So normally when there's no MCO, it's easy. You've got someone coming in and helping out, but during MCO, no one could travel. So caregivers were burnt out, and to call in private caregivers was very, very difficult. So mentally stressed out. So they would call us and ask us what to do, how to go about. So all we could do was just talk them through and teach them on relaxation and how they could just get some amount of respite. Now, communicating end-of-life issues with a PPE, using a face shield, face mask, not very easy. I had this beautiful 91-year-old lady, which I went in with PPE. First thing is when I was examining her, this is many, many months back, yeah. So I was actually talking to her, and she turns around because I was just fully covered, and she turns around and says, in Malay, "You don't like me, is it, doctor?" I said, "No." And I'm trying to smile through the mask and try to tell her, "No, I'm not angry. Why do you say that?" "No, I cannot see your face." So I kind of explained to her, you know, because of fear of transmitting things to you and fear of COVID, you know, I cannot remove this. But you see, being a 92 years old, and I don't think so she understood, she kept on repeating and repeating it. So I had no choice. I had to remove it. And the smile she gave to me when I removed the mask, she was so happy. So these kind of small things, this non-verbal communication, sometimes is quite important. But what I did subsequent visit is I still wore my mask. I went and saw her, but this time I thought is best way is to be more verbal. So when she says something, I try to laugh more so that she knows that, I mean, she can't see my smile, but she knows that, okay, nothing is actually affecting her or affecting me. Now, the other issue is patients wanted to borrow beds from us. Yes, we loan equipment. Everything is free of charge, but they have to get their own transporters. During the initial MCO, no lorry drivers wanted to come. They want to travel because scared of getting summoned. So patient's family, there was a patient who really, really needed a bed. He was sleeping on the floor on a very thin mattress. So one kind soul, we managed to get him to actually come, and this is he and one of our staff getting in the bed, and patient was so happy with this bed, and he died peacefully. Yeah, this is us teleconferencing and getting ready to go out. Now, the new norm, what are we going to do? How are we going to move on? Basically, we're going to continue on with whatever we've been doing during the MCO, but we're going to add on. See, right now we're just seeing dying patients, but we are going to start seeing more of patients with uncontrolled pain and symptoms and patients who have been newly referred to us. But yes, we still need to do the health risk assessment. And we would see if there is no risk, we'll go in. If we think there's some amount of risk, we would reassess and see the urgency. If we have to go in, yes, full PPE, we will definitely go in. And stable patients, we are still going to continue with teleconferencing. That is not going to change. And yes, safety precautions, like what Dr. Rozita has been saying. Yeah, we're going to continue with the whole thing of hand wash, full PPEs. We also intend to start doing pre-education videos like teaching of basic nursing cares and doing subcut injections so that family members have something to fall back on to help them through these difficult times. We are trying to get this EMS, electronic medical system, which I think so is going to be very beneficial because right now everything is on pen and paper. So it's because all the nurses are working from home with the electronic medical system to access these patients' medical records. It will be much easier. Yeah, that's it. Thank you very much.
Dr. Go?
Yes, you can begin now.
Sorry. Okay, my one is not working.
Okay, press okay.
Okay, hello? Yeah, unmute. Audrey,
What?
where's my, oh, unmute. How to unmute?
Press.
Your daughter is helping you. That's how wonderful working from
Oh,
home.
can you hear me, Dr. Go?
Very clear. Very clear.
Okay, thank you. Sorry. Yeah, I didn't know whether you all could hear me. Yes, so thank you and good afternoon for allowing me to share my humble experience as a hospice nurse. So first thing, the issue was, initially when the MCO started and also during the pandemic, we did have a shortage of PPEs, and so, but with the good spirit of the people and also volunteers, we...
Rozita, you have to speak louder to your mic, like just now.
Oh, can you hear me now?
If you can speak a little bit louder.
Louder, yeah. Sorry, what about now?
Yes, but it's better if you be closer to the mic or speak louder. Like just now, you were clear and loud. You may want to shout.
Yeah, so sorry, yeah. So actually using the PPE during home visits, it can be challenging as well because, with our hot and humid weather, you can literally feel the sweat as you walk up to your patient's home. And some of the patient's home, you have to walk 5 flights up. And also there is a distance, you have to park your car outside the security premises before you go into the patient's home. And so, yeah, and we use a lot of sanitizers and also disinfectant after our visits. And some of the challenges we face is roadblocks. And I was especially worried about whether the authorities, the police, would recognize our service, and one of our colleagues did get stopped by the authorities, because they were not aware of what hospice services is all about. And then with the letter of authorization, with the curfew 8 a.m. to 8 p.m. during the MCO, there was one family and the mother was, during her last final hours, and it was midnight. And one of the concern was, can they go to the patient's home, to their mother's house? And so what we did was I actually did call the police station, asking if it's possible enough for a family to travel and see their loved ones. And they were very kind enough. And I had to write a letter, official letter, and then they had to go to the nearby police station to get it approved. And so then they were allowed to go and see their mother. And no interstate travel was another challenge as well, because we had a patient, Mr. C, who was diagnosed with kidney failure and had only one wish, to return back to his original home in Kuala Kangsar, Perak. And, this MCO has made it his journey somewhat complex. And together with his family, we decided to write a letter and appeal to the authorities and prepare patient with subcut injections and continue even to provide service to them, though Kuala Kangsar, that is a remote area, so there's no other hospice to cover. And so we did that, and within 36 hours he passed away peacefully, surrounded by his loved ones. So I must say that we do try to make the impossible possible, and the family was very grateful. Yeah, what is this? Okay, sorry, yeah. No. So sorry. Okay, so there was definitely fear during this pandemic, and of course, my family was very worried of should I continue to work. And my daughter would even ask me, a question every time I go out to see patients: do I really have to go out? Can't I just stay home for today? And it's actually heartbreaking. And what I did was I would call them 5 minutes before I reach home. And so they would prepare everything, the towel, the soaps, all outside the house. And they would actually, I would actually bathe outside. I have also even considered renting a place outside, a room, in fact, fearing that I may spread the virus to my loved ones. And, at times I would get up in the morning and I will do self check, to see whether I have the virus or not. Temperature checking, especially. And but on the positive aspect of this fear is it makes me more diligent and more careful. It reminds me to use the hand sanitizers, to use glove, double glove. In fact, wash hands, frequently. So for our medical team, I would say that it's a nightmare as frontliners. We are afraid. We are also painfully aware that many healthcare workers have lost their lives, and we try to avoid contact with our family members until we go home, and we shower first before we even talk to them or even hug them. Patients and family members, Dr. Vanitha has mentioned earlier that some of them do prefer to do video conferencing and just calling them instead of physically visiting them. And the reason is because they said the family members or their loved ones are already immunocompromised, and so they don't want to increase the risk as well. So how we still stay connected to our medical team. I call it the cyberspace. We do have debriefing with our team ongoingly, and you can see there I missed that. So we frequently celebrate our colleagues' birthday and all, and we can't now. So we still keep in touch. We do have games and lectures online, and last week that was my first time playing charades online, so that was quite fun too. The pros and cons working from home: of course, flexibility of hours, no traffic jam, save time on driving, cost effective for the organization, I would say. But also this work demands more. It seems like we are working now 7 days a week, and there's no physical separation between work and leisure time. And it can be emotionally exhausting as well. Yeah. Thank you. Thank you, Dato. That's all.
So thank you very much, Sunita. And that ends our 4 speakers sharing on caring for vulnerable population. Don't worry, we know you're with your loved ones, Sunita.
Thank you.
So we now go to question and answers. In brief, we have Dr. Family Care Doctor talking about antenatal clinic kesihatan, how they continue to care for people who really need to visit their clinics for antenatal checkup and children for vaccination. And we have people with chronic liver disease, high risk of getting COVID, and certainly high risk for mortality. Then we have this wonderful home care hospice sharing how they continue to serve people at home through this difficult time. So we welcome questions. Please type into Slido. So first is the question to Vanitha and your team. They thank you for helping the needy one during this period of time. And certainly our community are so appreciating of the work you frontliners, real frontliners are doing. So now, first question, Rozita, do you think there's a need for us to assess the acceptance of our patient towards new normals in healthcare system? Basically, I think the way we are going to adjust and modify the way we care for patients. Your answer, please.
Yeah. Okay. Thank you for the question. Of course, we will need the feedback from our community. So we actually have done a Google form questionnaire, and we have submitted it through WhatsApp to the community, the people in Putrajaya. At the moment, we started off with KL and Putrajaya. So we have yet to analyze what they have their feedback are. But we do, yes, we do have that.
So I suppose your answer, you have already answered how you prepare for the virtual clinic and things. What are the second question is how are patients faring with virtual consultations? Are there any preparation needed, for example, training for both staff and patients?
Okay, so for this virtual clinic, we have what, like I've mentioned just now, we have started in August 2019, and throughout those months we have got continuous feedback. We also submitted Google Forms for these patients, and the feedback was very good. They like that virtual consultations, that virtual clinic, because basically number one is they will not have to come to the clinic. Number two, they will not have problems getting a parking space. Number three, some of our patients, one of my patients actually was doing her lactation. She was actually pumping her breast milk during that consultation, but we cannot see because we can only see her face, of course. So some was in the car, some was in the pantry at workplace. So they claim that they prefer this type of consultations so that it will save time as well. But of course, we will be very selective. Not all patients can be under our virtual clinic sessions. And for the training part, yes, initially when we recruited our patients, let's say, like I mentioned just now, patient who has taken blood test for starting on ACE inhibitors, took blood test and supposed to come in 2 weeks time. So before coming in 2 weeks time, we have already selected, oh, this is the patient suitable for our virtual clinic. So we have already primed the patient, got their consent, and teach them how to do it. So they have to download Skype for Business and on their laptop, and majority of our patients use their mobile network rather than using a laptop at home. So majority of them using mobile network. And of course, the younger group of people, they are more IT savvy, so no problems with them. But the more elderly patients, we will need to train their children. So during this MCO, training was done through the phone. We will call the patient and tell them, okay, we will tell them the guides, the step to step, what to do, step by step.
Yes, thank you very much. Next question also is for you. How about vaccination? We know we have a national immunization program where children have scheduled both in the clinic and the school. How do you go about it?
Okay, so right now for the vaccination, we are planning for a session where the patients will come to the clinic with their parents, and we will give them appointments, and they will get the vaccination in the clinic. So that is in the pipeline. We are starting it June, if I'm not mistaken. Yeah.
Yeah, thank you so much, Rozita. So I think I think this something new. The preparation will be done for all necessary service. So we now turn to Vanitha. Did the frequency of home visit or phone call reduce during this pandemic, and how far does this pandemic affect the hospice care? I think access to painkiller, etc.
Yes, the number of frequency of home visits, yes, it did decrease by a lot. But it actually, our phone calls actually increased. We were doing daily phone calls. So in a day, normally our home visits are like probably 3 to 4 patients in a day. But when it came to phone calls, we were able to call in more patients. Sometimes it goes up to 10 patients in a day. So about the care of the patients during this time. Right now, from what I can perceive and the feedback which we get from family members, I do not think that it has affected the care, because if a patient is dying, and these video calls have been fantastic, being able to see the patient, assess them, and if there is a need, and if we as hospice medical team can make a difference to keep patient comfortable at home, we would go in to provide care. If we find that no, the patient, there is risk, or patients just want to go back to hospital for final hours, they want to die in the hospital, we would make the necessary arrangements. We'll contact the hospitals and see how best for the patient to come in with ease. Thank you.
Yeah, follow-up question is, do you think the quality of death is affected during this pandemic, since the provision of palliative care is challenging?
The quality of death so far, I don't think so, because if patients dying, yes, we make sure that there is no pain and no symptoms. So, but even then, even if there is a pandemic, we would still go in if there is a need. So to ensure that patient has a good death.
I think we need to tell the families that they can actually ask for permission from the authorities like police to allow them to travel interstate or go to visit their loved ones. I think many are so scared, you don't even ask permission. So I think through your home care, through your contact with the family, do tell them that we can help them to get necessary permission to travel
Yes.
during the MCO. Yeah. Sunita, do you perform COVID-19 tests for patients who would like to return home to their family before their departure? I think this may be COVID-19 test for patients from the hospital to return home. Maybe we can share those patients being discharged and we care for them at home.
If when patients are discharged and return home, what we would do is we would have a set of questionnaires for the patient or the caregivers, and we will ask them if they, this COVID-19 screening questionnaires, such as any recent fever, cough, flu, or even diarrhea, any recent mass gathering, or any exposure to COVID-19 patient, and any of the family members or the relatives have returned recently from overseas. So these are the questions that we ask to all the patients or the family members before we do go in, and but not the COVID test itself.
Yeah, thank you. I would think for this person who asked the question, all COVID-19 patients are being admitted to government hospitals. So we have our guidelines to test before discharge. If any patient with acute respiratory illness like influenza like illness, they are all, or severe acute respiratory disease, they are all got tested. Normal cancer patient, if they do not have symptom or no high risk, they are not tested. So that's why it makes our home care team, like what Rozita's team, home care nurses to postnatal visit at home, and our the hospice service, they depends on this checklist, and that requires family members to be very sincere and truthful in answering those checklists. So, but that's why I see both of the teams wear full PPE when they visit patients. But as Vanitha said, some patients want to see your smiling face and things like that. So it makes it's certainly challenging in trying to do the best. I will have I have a question to Dr. Tan. You have done such a wonderful job to analyze and check on the publication on people with chronic disease and having chronic liver disease and COVID-19. What is your advice to other specialists who care for patients who may become something like chronic liver disease, like those who care for stroke patients, people with chronic heart disease and kidney? What is your advice to them to come up with something like what you have done?
She's mute. She's mute.
You can unmute. Sorry. You are unmute. You are mute.
Okay.
Your mouth because you are very much.
Okay. Can you hear me now? Sorry.
Yes, we can.
Yes, sorry. So I think, COVID-19 is a new disease, and certainly there's a lot to learn. And Malaysia being a country with multi-ethnicity, and of course, we also have, diseases, NCDs, and also infectious diseases. So I think this is a time that we need to look at our patients with COVID-19 in different categories, different specialties, subspecialties, to learn and identify new things, and also how to improve our care for these patients. I'm sure every other different patients needs special care, special information, prognostic information, and also by knowing that, we can actually improve our care for this group of patients.
Thank you very much. I hope, NIH is engaging others discipline as well to do research, and also with my family health. I saw one person asking about the research activities. Yes, we do have many projects ongoing. What we need is to gather all COVID-19 patients in government hospital and analyze their disease progression and outcome. So thank you so much, everyone. Before we end, we would like to ask each and every one of you to give a little summaries of your presentation and the message you want to send to many thousands of people now listening to our webinar. Dr. Rozita, you start first.
Okay, thank you, Dr. Go. Well, in summary, we are still seeing our maternal and child health patients. We are doing it as usual, but in a different manner. And we are embracing the new norm. And all the 3 C's and the 3 W's, please remember, it is not only to be practiced outside of our health facilities, it should also be practiced within the facility. Thank you.
Thank you. Community as well, especially the coming Hari Raya celebrations.
Yes.
Don't forget the message and our disease message. Next, Dr. Tan, Siam.
Yeah, I think in terms of liver disease, it is a double-edged thing. COVID-19 patients can develop deranged liver function by liver biochemistry, and also patients with pre-existing chronic liver disease also fare worse when they have COVID-19. So we have to be cognizant of this and look after our patients well. And of course, Selamat Hari Raya.
Thank you. Dr. Vanitha?
Yeah, I'm just going to make it simple. Hospice still persists during pandemic. Whatever challenges we face, we will still perceive on. Thank you.
Thank you. Sunita?
Well, despite the challenges we face, as what Dr. Vanitha said, we at Kasih Hospice is very strong, and we will do our best to try to provide hospice services throughout the areas of coverage. Thank you.
Thank you very much, everyone. Ladies, such wonderful presentation. It's very touching how you go on out to care for patients. We would like to inform everyone that the coming few webinar will be more on the collateral damage. So next week, we have a team of psychologists and psychiatrists, as well as resident or befriender, to talk about how are we affected by COVID-19. Following that, we have a panel who are experienced in treating dengue. So the early clinical presentation of COVID-19 is quite similar, fever, malaria. So we have experts coming to talk about how we learn the lesson from dengue infection by having a checklist for warning signs. So researchers in NIH as well as clinicians are now looking at the clinical presentation of COVID-19, and soon hopefully we will publish the warning signs so that people out there in GP and primary care will know how to differentiate between both. One is pandemic, the other is endemic. I think eventually COVID-19 will be endemic in the world as well, to differentiate the both, because the treatment and the diagnostic testing are all different. So stay tuned, stay safe, and keep our webinar going with these wonderful topics. And last but not least, thank you all the panelists, and Selamat Hari Raya.
Thank you very much.
Thank
Dr.
you very much.
Thank you.
Bye.